Next, we're going to call Gary and Betsy up to the podium to talk about our new National Quality Initiative on smoking cessation.
Thanks, Jens. We'll try to speed this up a little bit for this. We are proposing a new National Quality Initiative for smoking cessation. As most of you know, we already have two. One on discharge medications, which we've seen improvement in compliance with and saving people's lives. And the other is EVAR sac diameter. It's not been as effective, but we've seen an important progress for that. What is a National Quality Initiative? It is an outcome measure that we can measure and benchmark. It's an achievable measure that most centers can obtain by reducing variation or change in behavior. We ought to be able to measure it with PSO analytics. If you adopt it, what we hope to do as a National Quality Initiative, it will enhance survival, improve quality of life, and be more successful in procedural outcome. Tobacco use disorder, as you've heard, is the leading cause of preventable death. The CDC estimates that tobacco use disorder accounts for over 10 times more premature deaths than all the wars fought by the U.S. historically. Obviously, it's a major risk for cause of cardiovascular events, lung cancers, and particularly secondhand smoke increases the risk of death and disability. So it's not one of our friends. We can do this as a National Quality Initiative. Based on the results of the vapor trial and what you've heard previously, there's a three-component step to this to actually increase the patient's chance of smoking cessation. We propose a CAN-DO program in the VQI as a third National Quality Initiative. CAN-DO, choosing against combustible nicotine despite obstacles. You wouldn't believe how many things are trademarked regarding those phrases on smoking and quitting tobacco. I looked for probably 300 different phrases that weren't trademarked. Couldn't find one. This is the best we got. Tobacco abstinence saves lives, improves quality of life. Globally, we're not very good. About 25% of our patients who have a procedure are only successful at quitting smoking by the time they follow up with long-term follow-up. As you saw at Yale, they dramatically improved that percentage. It is that teachable moment, that targeted intervention that you have in a patient in the office that you can contact and talk to them about that with the advised assist method. So the CAN-DO program is to include smoking cessation variables in the arterial registries and hemodialysis access. Betsy will talk about that a little bit further. And we'll have webinar education for these rollouts in July. We are developing a physician and patient toolkit, which I will show you in a little bit, and also the SVS website content on smoking revision. We're revising the SVS page on smoking, which is not very good and is buried about 4 to 5 clicks within the SVS page. We're talking with the communications committee to elevate that profile and make it more patient-facing and patient-centered. We have already reported, and you should have received center level for physician reports on percent of smokers who've received smoking cessation information, and we'll provide further reports as we go on down the line.
That's our cue to trade places. All right, so the smoking cessation variables, there are already some in there. These are going to be for the arterial registries only. Many of you have already seen in the regional meetings, we have 2 reporting measures: pre-op smoking, again, elective procedures only, and then smoking cessation. Those include elective, urgent, and emergent. Currently, again, we already have some of the variables in our registries, and there's going to be minimal additional variables. We understand the data burden, and we don't want to overburden you. So we did take that into consideration. So we currently capture the smoking status as never, prior, and current. If the smoking status equals current smoker, we're going to have a new variable called history of smoking cessation counseling. You're going to have no, yes, physician healthcare provider counseling, yes, professional referral, yes, NRT, yes, Chantix, yes, Wellbutrin, other, and unknown. So we're trying to cover all of our bases. On the procedure form post-op, this will only show up if the demographic smoking is equal to current. Was smoking cessation offered after surgery or the procedure and before discharge? Again, no. Yes, physician, healthcare provider counseling. Yes, professional referral. And then yes, NRT, Chantix, Wellbutrin. And then other. And then for our long-term follow-up, again, there's no change. So you're going to have your select options of no or yes. And then we'll add a dependency if the procedure or demographic smoking equals current and long-term follow-up smoking equals no. Are they using an NRT? Are they not using an NRT? Or unknown? And again, you can do it. Dr. Lemon?
So the physicians will get a report back of the number of patients who are smokers in their office, and they will get a report about, did they initiate professional counseling? Did they initiate medications or NRTs? Did they initiate professional referral to a smoking cessation? You'll get that report back to see how well you're doing in terms of those patients who are smoking. The 3 A's or the 5 A's, if you want to improve upon them, as I said, it's probably not a good idea just to ask them, do you smoke? You need to go further on that. You need to ask them what they're smoking. Also, when is your first cigarette of the day? That can kind of tell you how much these patients are dependent on this process. Assist. Please use liberally nicotine replacement therapy medications. They can be used in combination. You don't have to prescribe only one. They work differently. Their onset of action is different. So use them liberally. Medications such as Chantix, Wellbutrin should no longer have a black box warning about their psychiatric effects. That's been proven through the Eagles trial that is not valid. So you should use them if that's what it takes for a patient to stop smoking. And the advice, all of our patients are going to have struggles with this. It's okay to fail. Get back up and start over again. It's never too late to quit. Even COPDers with chronic lung disease have an improvement in their quality of life stopping smoking late in the game. Physician toolkits. We have put in at least 6 different elements in the physician toolkits to assist you in this process of helping the patients to quit smoking. The vapor trial, as I mentioned, there's an excellent review by Nancy Rigotti on treatment of smoking, a review. Excellent. You need to read that. We have provided a visual dictionary of e-cigarettes that's very important to look at of what is out there. It's, as you've heard, over 250 million products for e-cigarettes from that standpoint. Patient-facing document will be in there as well. That's the SVS product. You'll see that briefly here. And then also an educational library. Please go out to the front, use this QR readers to get the patient toolkit and the physician toolkit is available for you through VQI. We're also providing billable codes for the discussion about this. You can get paid to talk about a patient stopping smoking. I won't go through all these bullets, but these are things you need to include. It's no longer going to be reimbursable or acceptable to reimbursement if you only say that you spent time counseling a patient and quitting smoking. You need to improve or include some of these bullet points on the side. The ICD-10 codes, there's probably about 40 of them, but these are the most common for cigarette dependence and smokeless dependence. And then the CPT codes that you're billing, I'll show you examples of these. They're either between 3 and 10 minutes time or over 10 minutes of intensive conversation from that. This is an example of a billable code for a short, This is an example of a billable code for 3 to 10 minutes. The red font here is highlighted about what is important in terms of those bullet points that you will be able to then get reimbursed for your conversation. This is an example of a 10-minute or greater conversation with the patients and all the bullet points in their risk and benefits and having a conversation and setting a target date for quitting and follow-up. That's all embedded in there. They're available in the physician toolkit. You can use these as smart phrases. This is an example of what we're going to be putting on a 2-page document for the SVS website. Obviously, the font is very small here, but it's a process that's actually kind of written in a patient understandable format. It's down to that language level that they can understand rather than the erudite process that we talk normally about smoking cessation. So please review that as well. And this is what's in the patient toolkit. These are various links. We didn't have to reinvent the wheel. This is already there. We are just putting them into a bucket so you can show them to the patient to give them that information for you.
All right, so for the patient education, this is all on the website, so I'm gonna, in the interest of time, I'm gonna go kind of quickly. But what we included are statistics, statistics talk. So it just, 30.8 million adults smoke cigarettes. We included about how tobacco companies target the audience. And again, 6 top reasons for smoking. Are you ready to quit? This is actually a picture by Dr. Mintz. She actually took it over in West Virginia. 1-800-QUIT-NOW, but still, it's very relevant. Where to begin and how to take the first step. And again, just keep in mind, this is for the patient toolkit, okay? Treatment options and phone apps. There's new cessation technologies. You've got text messaging, smartphone apps, web-based services. There's so many things out there for our patients. And again, we have podcast and YouTube videos. Some we already have on our website and others are coming. We've actually interviewed some of our patients, and they share their stories, and I think that's very meaningful for other patients to hear. We have featured ads and campaigns. I know you've seen all of these on TV, so also, again, these are real stories that patients can relate to. The smoking effects, PAD, stroke, all of these are, again, on our website. Telephone quit lines, for veterans, military, different languages. And then what happens when you quit smoking from 20 minutes all the way up to 10 after 10 years. And again, these are all statistics that really speak and drive home what quitting smoking does. And also cost savings. Look at this, 2 years, and this was whenever cigarettes were $7 a pack. Now I think they're like $10 or something, I don't know, I've never been a smoker. But, you can have a dream vacation for the family, 2 years of smoking. I was just like astounded. And then again, taking it one step at a time. Keep trying, again, as Dr. Lemon shared. It takes an average of 6 attempts at smoking cessation before succeeding. They can have experienced the icky threes, and just to remind them that they are not alone in this journey. And again, it's never too late, no matter the age. That's something else we wanted to target, because even over 60, they can still quit smoking. And then we also wanted to thank our Can-Do task force, Dr. Klein, the FDA, Dr. Spangler, Dr. Hinke, Jim Wadzinski, Dr. Ochar, Dr. Lemon, Dr. Mintz. We've just had such a wonderful and robust and committed committee to this National Quality Initiative, and also to you as well. We also have tons of references for patients and physicians. These are just a few examples for local and state, and then we have societal and federal. And even on the website, I have 6 pages already up, ready and running. And Jen, our marketing manager, has also helped. So we do have the website up and running. We have lots and lots of resources for you. It's not finished, but it is a start. And that's all that we have for you. So, Dr. Jorgensen.